of today, which is Malignant Ovarian Tumor, to be moderated by Dr. Lata Chaturvedula ma'am and Dr. Senthil Kumari ma'am. I take immense pride in introducing Dr. Lata Chaturvedula ma'am. Madam is a professor and HOD Obstetrics and Gynecology, JIPMA, and Madam is also a faculty of medical education at JIPMA. Madam is the president of Obstetrics and Gynecology Society of Pondicherry. Madam has won C.S. Dawn Award for the best paper at AICOG 2007 for advanced cancer screening training for gynecologists. Welcome, ma'am. And I also feel privileged in introducing our dynamic Dr. Senthil Kumari ma'am. Madam is currently professor and HOD Obstetrics and Gynecology at Mahatma Gandhi Medical College and Research Institute, Pondicherry. Madam is a certified sonologist and a well-trained minimal access surgeon. She's an excellent teacher with 17 years of UG and 14 years of PG teaching experience. Welcome, ma'am. The presenters are Dr. Sindhuja and Dr. Jay Pratibha from JIPMA. The presenters can introduce themselves to the short briefest, and you can then start your presentation. Over to you.
Good afternoon, everyone. I am Jay Pratibha from JIPMA.
Good afternoon, respected madam and faculty present here. I am Dr. Sindhuja from JIPMA, final year PG.
Good afternoon.
Good afternoon, and thank you, organizers, for giving us this opportunity, Dr. Shashikala especially. Thank you for organizing this.
Thank you, ma'am.
Thank you so much. I just want to say this is going to be a clinical case discussion. We won't be discussing much of theory because we just want you to know how to present in exams and what discussion goes on in exams. So don't expect to go, beyond what is expected you out of you as postgraduates. That's what we'll be discussing. Okay, Senthil, and thanks Senthil to be my co-moderator for this session.
Thank you, ma'am. Good afternoon, ma'am. Good afternoon, Shashikala ma'am, Lata ma'am. Thank you for the opportunity. I hope I'm audible, ma'am.
Yeah, you are audible.
Yeah, thank you, ma'am. Without much theory, we'll start the presentation, ma'am. Yes,
ma'am. Who's starting, Jay Pratibha or Sindhuja? Please start.
Sindhuja is starting, ma'am.
Yeah. Go to the history, please.
Is the screen visible, ma'am?
Yeah, it is. Go to the next slide. Yeah.
Our patient is 50 years of age. She's educated up to 2nd standard and residing at Pudukkottai. She belongs to socioeconomic class 4 of modified BJ Prasad classification. She's para 2 live 1, not tubectomized, and she's postmenopausal for the past 3 years. She has presented to us with complaints of abdominal distension for the past 5 months and abdominal pain for 5 months.
Okay, when a patient comes to you with abdominal distension, what things come to your mind? She is just postmenopausal for 3 years, right?
Ma'am, she's elderly age group and she's postmenopausal since 3 years with complaints of abdominal distension. So more likely we will think in terms of malignancy, we'll anticipate, ma'am. And among malignancy, we'll think more towards ovarian cancer, keeping other possibilities also in mind when we are thinking about cancer.
Okay, anything else? Or it's only
uterine mass. Other uterine causes also to be ruled out, ma'am.
Could it be a benign ovarian tumor?
Yes, ma'am.
When you think, it is possible that most likely it will be malignancy, but you should also think of benign ovarian tumors, right? You can't just say it is malignancy. Anything else? Uterine masses, what else?
If it is associated with CS cervix, she may present as pyometra, which is a mass per abdomen, ma'am.
Anything else? Mass or they'll develop, present as something. You said abdominal distension. Okay, one, it could be mass. The distension may be mass. Anything else? Could it be free fluid?
Ascites, ma'am.
Due to?
Either due to ovarian malignancy or even can be benign ovarian cyst can be associated with ascites can be there, ma'am.
Anything else?
TB abdomen, ma'am.
Tuberculosis. So don't rule out that. Don't think all abdominal distensions in a postmenopausal woman are only malignancy. Yes, our first diagnosis will move towards malignancy, but also keep other benign conditions in mind. Okay, go ahead.
She was apparently asymptomatic 5 months back, after which she has developed abdominal distension, which was gradual in onset, progressive in nature. associated with pricking type of abdominal pain, intermittent in nature, not radiating, and there was no specific aggravating or relieving factors. She also had bloating sensation and early satiety. History of swelling of legs was there for the past 7 days. There is no history of voiding difficulties.
Okay, you said about bloating sensation and early satiety. What does it mean? Where do you get such symptoms?
In advanced ovarian malignancy, ma'am, the involvement of peritoneum and compressions, and one more condition is that if the mass is so big, it may occupy the entire abdomen. Compression of the bowels, even in benign cases.
Yeah, in that also they can say complain of early satiety. Okay, and why swelling of legs?
Swelling of legs because she's having ovarian cancer. If it is advanced stage, it might be associated with the decreased urine output, causing a patient to go in failure, ma'am. Because of that, she can have swelling of legs. Or
have any voiding difficulty, no?
But compression of the greater lymphatics and the greater vein compression by the Mars per se.
Okay.
Can cause pedal edema, and ovarian carcinoma, deep vein thrombosis also to be ruled out, ma'am.
Of course, anemia. Most of our women are anemic also. You should think of those things also. Okay, go ahead.
There was no history of altered bowel habits, jaundice, hematemesis, melena, hemoptysis, bony pain, hirsutism or voice change. No history of chronic cough or evening rise of temperature.
Why did you ask about hirsutism and voice change?
Estrogen secreting tumors can present with hirsutism or voice changes, ma'am.
Estrogen.
Okay. And what about hemoptysis, melena, so much in detail? What do they
to rule out the metastasis, by asking this history, metastasis can be ruled out, ma'am. Like if there is hemoptysis, lung involvement will be there, parenchymal lung involvement, jaundice for liver involvement, liver parenchymal involvement, and bony pain, metastasis to the bone. So all these things can be asked, ma'am, for metastasis.
Where do this, I mean, if there is malignancy, where does it metastasize commonly to?
Liver, ma'am.
Thinking of ovarian malignancy. Okay. Okay, go ahead.
Menstrual history. She has attained menarche at 12 years of age. She had regular cycles and attained menopause for the past 3 years. She is postmenopausal. Marital history. She is married for 27 years. It's a non-consanguineous marriage. There was no history of hormonal usage or treatment for infertility. Coming to obstetric history, she is para 2, live 1. Both were spontaneous vaginal delivery, and her first baby died in the postnatal day 1. Second baby is alive and healthy, and she has breastfed the baby for 2 years. Past history. She's not a known case of tuberculosis, jaundice, thyroid, or renal diseases.
Sinduja, I have a question. See, can you go back to your previous slide? Yeah. So you specifically asked for the next slide. You specifically asked for history of hormone usage or treatment for infertility. That is one. Why have you asked for that? And did you ask the patient why she did not plan further pregnancy? She just had one child and one child has died.
Yes, ma'am. The husband has abandoned the patient, ma'am.
Oh, the husband has abandoned the patient. Okay.
Yes, ma'am.
Okay. So, and these two pregnancies were conceived on time.
Yes, ma'am.
Okay. And why is this history of hormonal usage and treatment for infertility?
Hormonal usage, both if gonadotrophins have a high risk for carcinoma ovary, ma'am, and treatment for infertility. So we have asked that history, ma'am. Oral contraceptive usage has a risk reduction of 50% when used for 5 years, and even after stopping, it has a protective effect for 12 years, ma'am. So we have asked that history, ma'am.
Okay. But what is the problem about taking hormonal treatment? If they're taking hormones, is there risk for anything else? The risk for ovarian tumor is reduced.
Yeah.
But is there a risk for anything else? It's progesterone containing. Any other tumors in the women?
Breast carcinoma. Breast carcinoma.
Yeah. So either way, they may be prone for the malignancy. Okay. But still, when it comes to ovarian cancer, it definitely reduces the risk. Go ahead.
Past history, she's not a known case of tuberculosis, jaundice.
Go ahead.
Family history, there is no history of ovarian, breast, or GI malignancies in the family. Diet history, she consumes mixed diet and she has a reduced appetite for the past 7 months.
Why did you specifically ask for ovarian, breast, and GI malignancies?
associated with BRCA1 and BRCA2 hereditary carcinoma.
Any other malignancy?
Any other? Yeah.
Lynch syndrome also.
Yeah, in that any other, you have, all these are associated with Lynch syndrome. Any other malignancy specifically you would like to ask? What about family history of endometrial cancer?
Yes, it is associated with like synchronous tumor, and Lynch 2 syndrome per se has a high propensity for endometrial carcinoma, ma'am.
Yeah. Go ahead.
On general physical examination, patient is thin built. Her ECOG performance score is 3.
Okay, Jayapati ma'am, you've spoken about ECOG performance status. So for benefit of everyone, can you just tell what it means? What does ECOG stand for and what does it mean?
European College of ECOG performance score 1 is actually she will be able to do all her routine daily day-to-day activities. ECOG performance score 2, she will be able to do her activities but with minimal restriction of strenuous activities. Score 3, she will be able to perform her routine activities also, but she will not be able to do with much efforts. And 4, she will be mostly bed rest bound, ma'am. And 5 will be dead.
So is it necessary to know the ECOG status of every patient?
Yes, ma'am. In cases of malignancies, it is essential to know, ma'am, because further management depends on that.
Whether you will take her for surgery or
whether chemotherapy will be planned will be based on the ECOG performance score, ma'am.
Okay. Okay.
Pallor was present, bilateral pedal edema is present, no ictus, lymphadenopathy or cyanosis, breast examination, nipple areolar complex is normal, no palpable lump is there, no thyromegaly. Her height is 151 centimeters, weight is 45 kg, BMI is 19.7, pulse is 88 per minute, and BP is 120 by 68 millimeters of mercury. On per abdominal examination, inspection, abdomen is grossly distended, all the quadrants move equally with respiration, umbilicus is pushed up, and skin over the abdomen appears normal. No dilated veins are there and no hernian orifices are free. And on palpation, a large abdominal pelvic mass of 20 to 20 centimeters is palpable, occupying the right inguinal, hypogastric, umbilical, and right lumbar region, firm to hard in consistency, with irregular surface and irregular margins. Lower border was not made out. Restricted mobility is there. And
one second, you said, okay, in inspection fine, abdominal mass is at 20 into 20 centimeters. At the same time, you are saying lower border is not made out. Then how do you know it is 20 into 20 centimeters? So what is a better way of presenting when you don't know the lower extent of the margin?
Corresponding to how many gravid size uterus, 26 to 28.
That would have been a better way of doing, especially when you know you can't make out the lower border. You clearly mentioned that the lower border is not made out, right?
Yes, ma'am.
Yeah, in that cases, see, for gynae, you can always tell in terms of uterine masses until the mass is freely mobile and it is more in the upper abdomen and lower border is very well felt. Okay. And usually, okay, go ahead. So what does this indicate? A large abdominal pelvic mass, hard in consistency, irregular surface.
Probably it is malignancy, ma'am. Arising and appearance, the firm to hard in consistency, irregular surface, and the borders not made out is all suggestive towards malignancy, ma'am.
Okay. We'll go ahead. Okay, go ahead.
Where did you feel this 4 into 3 centimeters nodularity? You mentioned
in the right upper quadrant, ma'am, in the hypogastric region. That was a nodular mass was filled separately from the abdominal pelvic mass, ma'am.
Is it in the abdomen wall or is it inside the abdomen? Where is it?
It is not in the abdominal wall, ma'am, because we did the leg raising test and we couldn't find that mass more palpable, ma'am, on leg raising test. Okay. It was a separate mass felt and it was nodular also. But no hepatosplenomegaly was there. And on percussion, dull note was there over the mass. Shifting dullness was present. And in auscultation, bowel sounds were heard. No bruit was heard.
Again, why do you talk about bowel sounds in a patient? Does she pass stools?
Yes, ma'am.
Then why do you talk about bowel sounds heard? See, this is okay for a patient who's constipated or obstipated, not for a patient who's regularly passing stools, right? You don't check just because you're taught all this should be done in an abdominal examination. Don't apply everything. Whatever is applicable to your patient, you'll have to talk about those things, right? Yeah.
On examination, external genitalia is normal. On perspiculum examination, cervix and vagina is healthy.
Can we go back one slide? Why do you think it's an ovarian mass? Why not a uterine mass? How do you differentiate on an abdominal examination an ovarian mass from a uterine mass, first of all?
Ma'am, on examination, if it is a uterine mass, it will be arising in midline and it will be firm to harden consistency. Whereas this mass is large, 20 to 20
Can you
centimeters.
have hard masses in uterine masses? Can uterine masses be hard?
Yes, ma'am, can be hard, ma'am.
So what are those masses which are hard to palpate? Usually, yes, uterine masses are firm to palpate, but what are those hard masses?
Leiomyosarcoma, it can be hard.
Why should leiomyosarcoma be hard?
When associated with degenerative changes, ma'am, like
Calculus degeneration is there.
Calcific degeneration, if it occurs, then only it's hard. Otherwise, usually you do not expect a fibroid to be hard, right? I mean, uterine masses, they'll be more of firm in consistency. Okay, then what else? What are the other differentiating features between an abdominal mass and an ovarian mass?
In a uterine mass, ma'am, we can find that a transverse mobility will be present, side to side mobility will be present. Whereas this mass, we will not be able to do that. And the consistency also, in case of ovarian mass, it will be cystic kind consistency will be there. And the lower border in both will not be able to made out, but in more of ovarian malignancy, ascites will be there. Ascites will not be associated with uterine malignancies. And apart from that, any other peripheral signs might be there. Metastasis, supraclavicular lymph node metastasis all will be there in ovarian malignancy, will not be there in uterine malignancies.
You should talk slowly. Whoever is talking, Sindhuja or Jayapratibha, you're very fast and you're mixing up some words. You're saying malignancy and benign, you're mixing up. You should be very careful when you use your words. Okay.
They've been, they're sticking to that. What is the mass in abdomen? You tell her.
So can you mute yourself?
Okay.
No,
All right.
I've just asked between uterine and ovarian. Don't talk about malignant and benign. I'm just
benign.
asking what is the difference between uterine and ovarian. How will
Slowly you answer. You should not be in a hurry to answer.
What else? I mean, should the uterine mass always maintain the contour of the uterus?
No, ma'am. It will be irregularly enlarged also. So it doesn't always require to be maintained the uterine contour.
One of the important differences, the lower border may not be felt in a uterine mass, whereas in an ovarian mass, you'll be able to feel. Of course, there are conditions where you, like in this patient, you may not be able to feel the lower border depending on where is the tumor arising from and how much. Usually that will differentiate a benign from a malignant mass. Okay, and uterine masses are mostly mobile side to side, whereas ovarian masses can be there in all the directions. Again, if it is a benign mass. Okay. So, like you said, ovarian masses, if it is malignancy, there will be variegated consistency. You can have a cystic, you can have solid areas and all, whereas uterine masses are mostly firm until unless they have undergone cystic degeneration or calcific degeneration. Okay. So that's how you differentiate. So how do you differentiate a benign from malignant mass?
From benign masses, it will be smooth in consistency. Margins will be irregular, and the surface will be cystic in consistency. And we able to get below the swelling also in an ovarian mass. Whereas in a malignant mass,
again, it depends on the size. You can have a large ovarian tumor, right, occupying the entire abdomen. So you may not be able to get below the swelling even in that case. There are smaller masses. Yes, it should be pedunculated. If they're not pedunculated, again, this problem may be there.
And mobility will be maintained in the benign masses. Whereas in a malignant masses, mobility will be less, the margins will be irregular, sometimes it will be variegated in consistency, and so surface will be variegated, and presence of ascites will be there in case of malignant tumors.
Usually, if ascites, it goes in favor of malignancy. Usually, yeah. Go ahead. Anything, Senthil, you wanted to say something?
No, ma'am. I was just saying that you will get other associated findings like hepatosplenomegaly or this nodularity like you felt in this case, like an upper abdominal mass may be associated in case of a malignant mass.
Go ahead.
On per speculum examination, cervix and vagina healthy.
I've told you many times when you say per speculum, that term per speculum itself is an examination. Either say speculum examination or per speculum. Okay.
Okay, ma'am. On bimanual examination, uterus is anteverted, normal size. The same abdominal mass was tipped and it was palpated in the anterior fornix and the right lateral fornix, ma'am. On rectal examination, there was a nodular mass of 5 into 6 centimeters, which is fixed and hardened consistency, which was felt in the pouch of Douglas. And rectal mucosa was free, ma'am.
Okay.
On summary, 50 years multiparous lady, not tubectomized, postmenopausal since last 3 years, presented with complaints of abdominal distension, with loss of appetite, with swelling of legs, with no comorbidities, and no significant family history. A large abdominal pelvic mass of 26 week size is palpable, hardened consistency with restricted mobility, and with ascites. And on per vaginal and per rectal examination, there is a hard nodular mass with restricted mobility felt in the pouch of Douglas, with rectal mucosa free.
Okay.
So diagnosis is 50 years, multiparous postmenopausal women. Case of ovarian cancer.
Not women, it's women. Yeah. Okay.
Probably malignancy in origin.
So you feel malignancy because of whatever you have discussed, right?
Yes.
In this case, what is in favor of malignancy in this patient? Tell all the points which are towards malignancy.
Age, ma'am, she is postmenopausal. And coming to her symptoms, she has presented with abdominal distension, loss of appetite, and it is there, ma'am. And coming to examination finding, she's thin built and she was looking cachexic also. And pallor was there, bilateral pedal edema was there. And on parabdominal.
Pallor will not tell you whether it is malignant or benign, right?
Abdominal findings are suggestive of a hard mass, which is having irregular surface, and there was restricted mobility, and it was not we were not able to get below the swelling, and it was kind of a fixed mass. And one more nodularity was noted in the anterior abdominal wall.
Sindhuja, can the organizers kindly mute others? You are the host. No, you can mute Sindhuja except me and Dr. Senthil. Yeah, go ahead. Sorry. Go ahead.
Coming to the abdominal examination, the mass was hard in consistency, ma'am. Surface was irregular, and there was presence of ascites, and mobility was restricted. And additional feature, we had a nodularity which was noted in the anterior abdominal wall, which may be due to omental caking also. And on rectal examination, pouch of Douglas nodularity was noted, which was hard, fixed, and mobility was less, restricted mobility.
Okay,
So all these features.
Yeah, you said about this nodule in the upper abdomen, right? Could it be anything else? I would still say it could be an abdominal swelling, nodule in the abdominal wall. What is Sister Joseph's nodule?
Metastasis to left.
Periumbilical nodule, ma'am, due to metastasis from the lower.
Okay, so it could be present that. I mean, that shows. So with this, what is your diagnosis? You said probably malignant in origin with all these findings. Would you like to stage the disease here clinically?
Clinically, on examination, the mass of 20 to 20 centimeters, ma'am, it is extending and occupying the lower whole quadrant. And there is also another mass which is felt in the pouch of Douglas of 4 into 3 centimeters. So probably it is extended into the pelvis below the pelvic brim. So without any other lymph nodes, clinically palpable lymph nodes. So we would like to grade it as stage 2 ovarian cancer, ma'am.
Why stage 2? You have also done a rectal examination. You found a nodule in pouch of Douglas. So, and you are saying there's a nodule in the upper abdomen.
Rectal mucosa is free.
Omental caking.
Rectal mucosa is free.
Okay, you said about omental caking.
It can be omental caking, ma'am, but it is clinically we cannot tell exactly if it is.
So why can't you put it a higher diagnosis? Why are you still thinking it is stage 2? If you are thinking it could be omental caking, see, finally this is not going to be your final diagnosis, right?
Yes, ma'am.
So your staging will depend on other things. So clinically with this, can you think of stage 3? Okay, if you're saying stage 2, what prevents you from staying it to stage 3? What is stage 2 disease?
Stage 2 is extension to the other pelvic extension is there, ma'am, below the level of pelvic brim.
So you feel that there is no extension into the peritoneal cavity? right? Except in the pelvic peritoneum, not in the
Lymph
abdominal
nodes we are
peritoneum.
not able to make out, ma'am.
But if you said momental caking,
Yes,
I
ma'am.
didn't say that. So if that is the case, then it should have been stage 3, right?
Stage 3, yes, ma'am.
Stage 3 what?
3C.
A, B, C.
3C.
What is the
3C,
size of
ma'am.
the tumor?
That was 3 cross 4 centimeters, ma'am.
Okay. So it is more than 2 centimeters, right? So keeping this diagnosis in mind, how will you go about? Why not benign?
And there is no feature suggestive of benign disease on abdominal examination, ma'am.
Okay. So you think it is terms of malignant ovarian tumor. Okay. Suppose we just think, forget about these features. If you had a woman who had a mass similar size, 26 week size with smooth walls, okay, no ascites. What will you do? Postmenopausal woman. Same patient. What will you consider in that patient?
We can
There's no
consider
free fluid. Yeah.
benign ovarian cyst, ma'am.
So how will you assess that? So what will you do now?
We'll do a transvaginal ultrasound and
I said
That's a
26
huge
week size mass, you'll do transvaginal.
trans-abdominal ultrasound and then followed by tumor markers, ma'am.
Okay, just tell now that first thing you would like to do a abdominal ultrasound, right? In this
Yes.
patient or even the scenario which I have given. So how will you differentiate a benign or malignant on ultrasound examination?
On ultrasound examination in benign, there will be a unilocular tumor, ma'am. Most likely it's
Always benign masses are unilocular. Is it like that? Can you tell me one benign mass which could be multiloculated?
Mucinous cystadenoma.
cystadenoma, mucinous cystadenoma.
Usually, if it is multilocular, it will go in favor of malignancy, but mucinous cystadenomas could be multilocular. Okay, then.
And on ultrasound examination, in malignancy, we will have solid components will be there, ma'am. And other features suggestive of malignancy will be ascites with surface irregularities and papillary excrescences will be there. Vascularity increase in blood flow will be there.
I want to know. Where you have a 26 weeks size mass, which with smooth wall, no ascites.
Ma'am, actually, the first part of it got cut off, ma'am. When you started, I think
Sorry.
network went off. Oh, you have to
Okay,
repeat the
sorry.
question. Yes, ma'am.
Okay. You said you've done can you hear me now?
Yes, ma'am.
Yeah. So you're going to do an ultrasound examination, right? So you say, I could hear you. You people said you will find unilocular or multilocular. Okay. Then you said Doppler. You said ascites. So is there any scoring? Suppose this woman did not have any features, like I said, malignant features on clinical examination. Is there any scoring system which we can utilize to differentiate a benign from malignant while doing ultrasound?
RMI score can be used, ma'am.
What are the various scoring systems? I mean, just for everyone to know, what are the various scoring systems available?
ROCA, risk of ovarian cancer algorithm, I'm using CA125. ROMA, risk of ovarian malignancy algorithm using human epidermis factor 4. And RMI, risk of
factor 4, yeah.
RMI score, which uses ultrasound criteria, CA125 and menopausal status. Other scores are like IOTA scoring, International Ovarian Tumor Analysis scoring system, where we consider B and M features for classifying the tumors. The newer scoring system is ORAD scoring, where it is classified into 5 stages and each has a percentage score, ma'am. 0, there is no tumor. 1 will be like normal, and 1 is less than 1% of ovarian malignancy. Then score 3 will be like each score-based criteria is there in ORADs, ma'am.
Okay, ORADs is a relatively new thing. IOTA is something which we all keep talking about. What is it? There is a comment that you people are very fast. Okay. What is IOTA? What is RMI? Can you clearly tell? What is ROCA? What is ROMA? So many are there. So finally, which is the best, which we can use for identifying which is malignant and which is benign? Is there anything like that?
Risk of malignancy index can be used, ma'am. We are using 3 criteria. One is CA125. Second is menopausal status, and the third one is ultrasound features. If ultrasound features are not there, then it is equal to 0. And if
that is the problem with RMI, especially 1. If it is 0, then the whole score, even if our menopause CA 125 is suppose 200, okay, and menopausal status, what is the scoring given?
3, ma'am.
postmenopausal 3, premenopausal 1.
So 3 into 200 into 0 will be 0. That means she doesn't have any risk of malignancy. That's why RMI 1 is not used, whereas RMI 2, 3, 4, depending on the menopausal status, you can use. Whether the minimum ultrasound finding would be given a score of 1, right? So that way you can calculate. Whereas RMI 4 also looks into the size of the tumor.
Size of the tumor.
Less than
RMI
7
4
centimeters
and
or
more than 7 centimeters.
So when you don't have very, you know what to say, I mean, you don't have much of expertise, that may be still okay to use RMI scoring. Something is better than nothing. What about Roma and Roca? How is it different? How is Roca different from Roma?
Yes,
You said no?
Yes, ma'am. In Roca, we use only CA 125, ma'am. For
That
serial
is
monitoring of CA
measurement.
125.
That means you have to wait for a long time to see. So if it is going to be malignancy, you'll be
Malignancy,
wasting a lot
we
of time.
missing the
Yeah. And in Roma, you are going to do the HER2.
Human
Right?
epidermis protein 4.
Yeah.
and
So,
it has a
HER4,
disadvantage, like in later stages, the sensitivity and specificity will be very less, ma'am. So
and also expensive, right? So, okay. So what about iota scoring?
It is whether it is benign or malignant, ma'am. Same features, whether the cyst is either it is a cystic consistency or irregular solid tumor is there, or
So
if the
one more, yeah. So tell the 5 factors, Amma. What all will you look at in the iota scoring?
Consistency, ma'am, smooth solid consistency in benign cyst, whereas in malignancy it will be irregular solid tumor, ma'am. With solid components will be there in malignant one, and papillary excrescences will be there in malignant one. And
yeah, again, the number of papillary excrescences matter,
at least
and
4
the
should
size.
be
Less
at least
than
4 papillary excrescences, and with multiple septations,
3 mm.
with a thick septation, septal thickness at least more than 3 mm, and ascites will be there, ma'am, and resistivity index less than 0.4.
Are you mixing up something? Yes, sir. Sir, go ahead.
Let her tell all the B rules once and M
Yes.
rules. Mixing up both is very confusing.
Yeah.
Talk slowly, tell all the B rules. Don't say this is cystic, there is solid, like that. Don't confuse. In B rules, what are the B rules? You just tell, enumerate.
Yes, Sindhuja, say. Audible?
ma'am, we are audible.
Can you hear? Tell what are all the B rules in iota? What are all
Did you hear
the...
my question, Sindhuja?
Sir?
Did you hear my question?
No, sir.
Enumerate all the B rules first, then go for M rules. Understood?
Yes, sir.
Okay.
International Ovarian Tumor Analysis classifies ovarian tumor into B and M rules, where B rules will be benign rules and M will be malignant rules.
Okay, what is B and what is M? You should tell that.
Enumerate all the B.
What are all the B rules, Amma?
Ma'am, can you hear us, ma'am?
Yeah, we can hear you. You tell.
Nicely audible, tell.
Malignant features can we tell, ma'am, first?
Okay, either one you tell one
No.
continuously. Don't
In the
mix up
exam,
both.
you are
Always
asked B
tell
rules.
B.
No, in
Yeah.
the exam, you are asked B rules. Tell B rules first. Why should you start whatever you like? You know the B rules. You started actually. Tell all those. It's okay.
Sir, solid cystic tumor, sir, benign one. Absence of blood flow.
How it can be solid cystic
Solid
tumor,
cystic.
benign?
Anechoic solid cyst. Anechoic cyst, sir.
No.
Anechoic cyst.
Size?
Sir?
What is the size of the cyst?
10 centimeters, less than 10 centimeters, ma'am.
Okay.
Then absence of blood flow. Presence of acoustic shadowing.
Then
Absence of blood flow. Okay.
The largest cyst will be less than 10 mm.
largest cyst will be less than 10 mm.
With no solid components or papillary excrescences.
What should be the size of papillary excrescences?
3 mm.
3 mm.
No, if there is a raised area, it should be less than 7 millimeters. There should be acoustic shadowing behind. You told that, I think.
Yes, acoustic shadow, unilocular cyst, then
Less than 10 centimeters, not vascular. That's all you should tell. You need not even go for RA and
resistive
P.
index and all. If the papillary excrescences are 4 or more, or if there are solid components, no acoustic shadows, and increased vascularity, all will go in terms of B rule. See, this is important when you are clinically diagnosing. Why should we know about this scoring? So many things. We can just see an ultrasound and make out whether it is benign or malignant. No, why so much of scoring? How does it help us?
To arrive at the diagnosis of benign or malignant ovarian carcinoma, and so our management protocol.
It is not for you and me, it is for general gynecologists, so that you will make an early referral to the oncologist so that the treatment is properly done, rather than just doing some kind of surgery and then sending off the patients, which we know is not correct in cases of malignant ovarian tumors. If it is benign, you can manage on your own. If it is malignant, better to send them to a gynae oncologist. Yes. Okay, go ahead. So how will you manage this patient?
She is multiparous postmenopausal mom. So we would like to start investigations at the first time she's presenting to our in our OPD. We'll want to take a pap smear test, ma'am. Then after the pap smear test, we'll do one transabdominal ultrasound to look for the size of the mass and the presence of ascites. The tumor.
So in this patient, are you worried about the size? Clinically, it is palpable, right?
Yes, ma'am. Clinically palpable.
So what will you really look for in this patient on ultrasound?
Huge mass. What else will you look for?
Presence of ascites.
See, first talk about the mass. What all will you look for inside the mass?
The septations are there. What is the septal thickness? And
multilocular or unilocular, hard in consistency.
Solid components
are there.
Consistency doesn't come. That's
solid
a clinical diagnosis. Yeah, when you are doing an ultrasound, you look whether there are any solid areas. Okay, then what else?
Vascularity also we'll see, ma'am.
How does it matter in this patient?
If vascularity is increased, if she doesn't respond to chemotherapy or anything, later on we can give her targeted agents. If we are giving her,
depending on vascularity, you will decide all that. That too now. That is the last thing which we'll look about. Yes, ascites. Then what else will you look for in ultrasound?
The compression of the ovarian tumor can compress the uretus, causing hydroureteronephrosis. So we will want to rule at that. And uterus, also we will want to look at endometrial thickness and rule out uterine causes. If
how does it matter?
They can have,
will change.
Yes, ma'am. Coexisting endometrial malignancy can also be there.
So will your treatment change as of now?
As of now, it will not change, ma'am. But post-operative, whether if endometrial malignancy is associated with that, she might require adjuvant radiotherapy.
That is later. Right now, what else will you look for? Endometrial thickness, I won't give any importance right now. What else? Until unless you're doubting whether the mass is arising from the uterus at all. Anything else? Would you like to look at the liver?
Yes, ma'am. Liver metastasis is there.
And then you had a 4 into 3 centimeters upper abdominal mass. Wouldn't you like to assess that also on ultrasound?
Yes, ma'am.
I want to ask you one question. Should we straight away send her for higher imaging, or is ultrasound enough?
We have to do an higher imaging, ma'am, to rule out the lymph node status.
Then why do an ultrasound at all?
Ultrasound, in cases of peripheral setups, they can, with this ultrasound, they can come to a conclusion whether it is benign or malignant, based on which they can at least make a referral to a tertiary care center. And once they referred her to tertiary care center, we can decide the further operability and assess it with higher imaging modalities.
Then what else will you do? She's come to our institute. What else will you do?
We would like to do tumor markers, ma'am. Tumor markers, we can do CA 125 and CEA we can see, because mucinous or serous tumors are the ones we expect. So we can do tumor markers. Then other than that, based on the tumor markers and ultrasound examination, we'll be able to arrive whether it is benign or malignant, based on which if it is suggestive malignancy, then we would like to go higher up and do CT or MRI. CT scan we would like to do, ma'am, to decide on the exact location of the tumor, the size, and the extent of metastasis.
What is that which you miss on ultrasound that you can get on CT?
Even the smaller ones which might be missed on ultrasound can be picked up on CT, ma'am.
So where will you look for the disease in CT? See, generally about the mass, you get information, most information in ultrasound. So how does CT benefit us?
We can look for the subdiaphragmatic deposits are there, or paracolic gutters if it is there, or chest, whichever areas which might be missed by ultrasound can be picked up on.
What about liver?
Liver metastasis can be picked up on parenchymal or extensive liver metastasis.
What about nodes? You should be systematic. You're jumping from abdomen to thorax, right? You said about involvement of pelvic peritoneum, involvement of bowel. Okay, you should talk about involvement of liver, then nodes. Does it matter to us? All this involvement of nodes, bowel, liver, whether liver parenchyma, liver surgery.
Based on that, we can assess the patient whether she will be a candidate for primary cytoreductive surgery, or we'll go about and give her a neoadjuvant chemotherapy, ma'am.
Okay, so the extent of the disease will help us in staging the disease better, and also finally make us aware that whether we should be able to, like you said, whether we should go for upfront surgery or go ahead with interval cytoreduction, right? Okay, what are the other things which you do? Any other investigations you want to do other than imaging?
Tissue biopsy.
Before that? Okay, tissue biopsy. All patients will you do tissue biopsy?
When we are planning for a primary cytoreductive surgery, we don't do a tissue biopsy.
That will come to a bit later. Any other investigations you would like to do?
Cytology, ascitic fluid cytology we can do.
That's what we said. We'll come to a bit later. Any other blood investigations you want to do?
Markers you said, no, before?
Yes, ma'am.
Complete blood count, RFT, LFT.
As a part of preoperative workup. Other than that, we would like to do chest X-ray, ECG, echo.
See, those can be both preoperative workup, and also suppose you have done a liver function test and it's elevated, right? Then you'll also, why do you think it should be elevated, which is very unlikely? Yeah.
Involvement of the liver due to metastasis, ma'am.
Okay, if parenchymal involvement is there, you may get an abnormal liver function test. In that case, we are in a dilemma whether we should give chemotherapy, whether she may not be a candidate for both, right? Both for surgery and chemotherapy. We'll have to look into all that. We may have to go in for palliation. So it's important that we assess the status of the patient beforehand before we take them up for cytoreductive surgery or chemotherapy. Now you tell me, what is the role of doing a colonoscopy or upper GI endoscopy in these patients? Should we do?
In CA 120, CEA is raised or CA 19 is raised, then we go about and do colonoscopy to rule out, to find out the primary, ma'am.
Is there any other way to make out whether it's colonic or ovarian cancer? You have done CA 125, you have done CEA.
CA 125 CEA ratio. If it is more than 25, then it will be suggestive of CA ovary, ma'am. If it is less than 25, it will be a primary GI malignancy.
Usually it's like that. Yes, if it is less than 25, we have to consider primary GI malignancy, in which case, yes, you may go ahead and do endoscopies, which become very important. Upper GI, most of the times we can make out on CT, but sometimes we may still miss. So in those cases, we will definitely do an upper GI endoscopy or sigmoid colonoscopy. Okay, so now in this patient, you tell me, how will you decide the mode of management?
We have to assess her performance status first. She's performance status 3, ma'am. And based on the imaging, if there is, whether we can go about and do a primary cytoreductive surgery, or is she a candidate for neoadjuvant chemotherapy?
These are the cases where you can straight away go ahead and do primary cytoreductive surgery, primary upfront surgery.
Ma'am, without involvement of porta hepatis, there is no involvement of stomach or gut involvement, diaphragmatic involvement, lung parenchymal involvement. If all these are not there, then we can straight away go and
Suppose she has a subdiaphragmatic growth of around 7 centimeters or 6 centimeters in size. Will you like to go ahead with upfront surgery? So again, it depends on the stage of the disease, right? Maybe still. Can you, what is the staging? Can you just tell the staging of ovarian tumor?
Yes, ma'am. Stage 1 confined to the ovaries, ma'am. And stage
1B, 1C is there, ma'am. 1A confined to only one ovary. 1B, if it is confined to both, one or both ovaries or fallopian tube with the surface capsule being intact. 1C1 is a surgical spill. 1C2 is the capsule has ruptured before the surgery. And 1C3 is positive peritoneal cytology or ascitic fluid washings are positive. Stage 2 is spread outside the ovaries and spread to the pelvic extension is there, but below the level of pelvic brim. Stage 3 is spread is happened outside with cytologically or histologically confirmed positive peritoneal metastasis is there, can be above the pelvic brim. So 3A1, 3A2 with retroperitoneal lymph nodes less than 10 mm and more than 10 mm, 3A1, 3A2. 3B is extra pelvic metastasis, macroscopic deposits, microscopic deposits will be there. 3C1, 3C2.
Are you sure? Are you sure about the staging of 3A? You said 3A1 and 3A2. What you told is not correct. A11 is what you said, less than 10
10
millimeters.
retroperitoneal lymph nodes.
And
A2 is more than 10
millimeters, 10 millimeters is 3A12. 3A2 is microscopic peritoneal deposits. Okay. 3B is when the tumor size is macroscopic and less than equal to 2 centimeters inside. Yeah, extra pelvic only. All this is extra. Once you say stage 3, it's all extra pelvic disease. Okay. Stage 3C is more than 2 centimeters in size. That's how it should. See, does it matter? Why should we differentiate into 3A, A1, A2, A3, 3B, 3C? Why so much of differentiation? Why not have just stage 3A or B, or stage 3? Why so much of importance is given to the size of the tumor?
If the lymph node assessment is done properly, it will be undergrading the tumor and she will be treated like as stage 2, ma'am. If the lymph node involvement is not assessed properly,
it will also tell you the prognosis, no? The stage of the disease will maybe grossly we say 15. 15% of them will recur, 30%, like that will say. If you take stage 1, almost the survival is more than 90%. Stage 2, it's somewhere around 70%. So the survival prognosis depends on the stage of the disease. So by dividing so much, individual staging will tell you the prognosis so that you can explain to the patients when we are advocating the treatment to the patients. That's how it becomes important. Again, if the liver surface is involved, it becomes stage 3.
PC only, ma'am.
If liver parenchymal is involved, then it becomes stage 4. What about supraclavicular node? What about inguinal nodes?
Inguinal node will be 4B, ma'am.
Supraclavicular also 4B.
Will be 4B.
So again, this is important for us because so many trials, so many things are going on. So whether to decide the treatment strategies. So in stage 2, what would you like to do? Stage 1, the treatment is surgical, or you want to do anything else?
Surgical, ma'am.
Okay, like that, can you tell in which stage you would not go directly for surgery? So how do you decide that?
Based on the ECOG performance status and whether...
That is one. Patient's performance status may be good, but still I may not want to do surgery at all.
Advanced ovarian malignancy, it's stage 3, C and 4, ma'am.
Yeah. Stage 3 even depends on stage. If one thing is, if you have the expertise to remove the entire thing, you can debulk the entire tumor, then it's okay. You can go and do the upfront surgery. If you go, oncologists can do even to stage 3 or sometimes even stage 4, they will say they'll do, especially if only one lobe of the liver is involved. But otherwise, it's better to go ahead and give a neoadjuvant chemotherapy. Okay, so you have the options from still stage 2, you can definitely go ahead and do surgery. From stage 3 onwards, there is an option for giving neoadjuvant chemotherapy followed by debulking, right? You do give chemotherapy, do the interval surgery, and again give 3 cycles of chemotherapy post-operatively. Now for doing that, okay, how do you decide? How do you decide chemotherapy should be given or not? What is necessary? Is it mandatory that you need to have tissue biopsy?
Yes, ma'am. Without tissue biopsy, chemotherapy cannot be given. So before starting a neoadjuvant chemotherapy, we need tissue diagnosis either from ascitic fluid cytology or from the mass per se, ma'am.
Which one will you decide? How do you decide which is better?
The ascites is tense and it is easily if can be done ascitic tapping, then we'll go about and do an ascitic
the sensitivity is many a times very poor. So if you do ascitic tapping, you should be sure that it's going to be positive for cytology. Otherwise, you won't give chemotherapy. Otherwise, you can go ahead and take a tissue cut biopsy from the nodule itself, either vaginally or from abdomen. This can be ultrasound guided. We need not even do a CT. Okay. So what is the common ovarian tumors? What is the common histopathology you come across? In this patient, what do you think is the tumor?
It can be
adenocarcinoma of the ovary, ma'am. High-grade adenocarcinoma of the ovary.
Adenocarcinoma means what?
serous or mucinous, ma'am.
So you most likely it is epithelial tumor,
Epithelial
right?
ovarian carcinoma
Could be serous tumor. Okay, then.
Other than that, endometrial or clear cell type can be there, ma'am.
Most common will be epithelial ovarian carcinoma in this age group, ma'am.
So when will you suspect other tumors?
In relatively younger age group, and when they're presenting with features of abnormal uterine bleeding with dysmenorrhea, such conditions will think of other tumors, ma'am.
Dysmenorrhea, why dysmenorrhea?
In younger age group, when they're presenting with dysgeminoma or other conditions, in that age group, we will suspect, ma'am. But in this age group, epithelial ovarian cancers will think.
Could it be anything else? Postmenopausal woman? What is the other group of tumors you can see in these patients? I agree, most common is epithelial, surface epithelial tumors, which are the most common tumors. Could it be any other group? What about sex cord tumors? In which age group is it common?
In the first 2 decades of life, ma'am.
Sex cord tumors. Granular cell tumor, when does it occur?
First 2 decades.
In which age group?
20 to 30 years age group.
Don't you see in postmenopausal women?
Yes, ma'am.
They come with one of the causes for postmenopausal bleeding. You also think of that, right? It may not be very common like epithelial tumor. You should rule out. Yes. In these patients, it's not really common. Okay. So now you have got a tissue diagnosis. Now tell me, how will you go? Suppose I want to give, go for interval cytoreduction. How will you give neoadjuvant chemotherapy? What are the drugs which you give?
We give carboplatin and paclitaxel, ma'am. Paclitaxel, we give 175 milligram per meter square over 1 hour. IV we give, ma'am. Then we can give, along with that, we have to give carboplatin with area under curve at least maintaining 5 to 6 based on GFR.
Okay, it's also very important that you maintain hydration for this patient. Give good pre-chemotherapy IV fluids so that it will provide. We should give IV fluids and give antiemetics for these patients. Do we give or we don't give?
We give, ma'am.
Why?
To reduce the toxicity, ma'am. And one more thing, they have high hematogenic.
No, IV fluids and hematogenic, how does it matter? See, most of these chemotherapy
side effects?
causes,
Side effects.
what do they cause? Yeah. Vomiting is very common, right? You don't want them to go in for dehydration, right?
Yes, ma'am.
Yes or no?
Yes, ma'am.
Or you think they don't have any vomiting with chemotherapy agents? All the others are only, see, I agree, other toxicities are common, but most of the chemotherapy drugs cause vomiting, right? So you don't want them to go in for dehydration, right? Okay. What are the toxicities? Why not cisplatin? Why carboplatin? Cisplatin is time tested, very good for ovarian tumors.
It causes nephrotoxicity, ma'am. Renal failure, some patients will have renal failure also. So.
Yeah, it's highly nephrotoxic. That is a common problem with cisplatin. So we prefer carboplatin. But what is the problem with carboplatin? No side effects with carboplatin?
It causes immunosuppression, myelosuppression.
Myelosuppression can occur, but definitely better than cisplatin. It's known, I mean, all chemotherapy drugs will have side effects, but we have to treat the tumor per se. What about paclitaxel? What is the problem with paclitaxel? What is the side effect?
Peripheral neuropathy.
Yeah, peripheral neuropathy for this patient. So how many cycles will you give? How long will you give? Are there any different ways of giving chemotherapy?
Yes, ma'am. Here we follow 3 cycles, and followed by that, we'll assess the patient for operability, ma'am. And based on that, we'll decide. Other modalities of treatment are intraperitoneal chemotherapy.
No. I'm talking about talking about abdomen. While giving chemotherapy, not all. This is called consolidated therapy, right? You give 3 weekly for 3 cycles. Then you assess 3 to 4 cycles. Then you assess and then decide whether you can operate them or not. Suppose a patient, your performance rate is very poor, 3 or 4, she will not tolerate chemotherapy. So then what do you do?
We'll give her a weekly based chemotherapy where dose reduction will be done, ma'am.
Yeah, that will be better tolerated. And after most of the times, after 2 to 3 weeks of giving this chemotherapy, they are better tolerant to chemotherapy. And then you can go ahead and give the further 2 to 3 cycles of chemotherapy, assess them again using CT, whether they have responded or not, and then go ahead and do a cytoreductive surgery. Now, before doing that, I want to know, what do you, I mean, suppose you're doing laparotomy stage 1, you're doing surgery, what is that called? And how is it different when you're doing for stage 3? What is the difference between surgical staging and cytoreductive surgery? Is there any difference or both are same?
Difference is there, ma'am. When we are doing a surgery for stage 1 disease, then that condition where we don't have a histopathological diagnosis. First, we are going to stage the patient the first time, when we label it as staging laparotomy.
Yeah.
Then once the patient has received 3 cycles of chemotherapy, then we are posting her for surgery in stage 3 or stage 4. We call this internal cytoreduction surgery. After 3 cycles.
When I said cytoreductive surgery, usually in stage 1 or stage 2 disease, will be able to remove all the tumor, right? In cytoreductive surgeries, whatever possible you try and remove. You may not be 100% in removing the disease. So that is the basic difference. Whereas when you do in stage 1 or stage 2, most of the times you'll be able to operate and remove the entire disease process. Whereas in stage 3 disease, okay, you only do cytoreductive. That means in stage 1, suppose it's stage 1A or stage 1B, you also remove the nodes, right? It's not just palpable, you do complete and parietic lymph node dissection. Whereas in stage 3 and all, you only remove the nodes which are enlarged. Even during interval debulking, normally in interval debulking, you do not do any pelvic or parietic lymphadenectomy unless they are enlarged. Okay, so that is the basic. So in cytoreductive surgery, you try to remove as much as tumor tissue as possible so that they'll be responding better to the remaining dose of chemotherapy which you give. Or if you're giving adjuvant chemotherapy in an upfront surgery, they will respond better. If you're going to leave back a lot of tumor tissue behind, then the response to chemotherapy is not good. Okay, what is refractant? Will all the patients respond to chemotherapy, or there is any difference?
There can be refractory disease or resistant disease, ma'am.
What is refractive, platinum sensitive, platinum refractory, and platinum resistance? How is it different?
If the recurrence occurs after a primary treatment within 6 months, then that is called refractory disease, ma'am.
No.
After 6 months.
No. When we
resistant disease.
Yeah, I'll just tell. When the patient comes to us after 6 months of stopping treatment, after 6 months, that means you have done the surgery, you have done whatever chemotherapy, everything. After 6 months of stopping treatment, beyond that, then it is called as platinum sensitive. Platinum sensitive. They'll come back to us. Then you can again give them platinum. When you say resistant, they have come, the recurrence has occurred, or they've come back to us within 6 months.
6 months.
That is resistant. When you say refractory, either the patient has not responded at all, or while on treatment, she has disease progression. These are the patients who may not respond to any types of chemotherapy, whether second line or whatever line of drugs. Whereas in platinum resistance, you can still try. See, they have come back with a recurrence of within 6 months. You can still try platinum based drugs again. If they don't respond, then yes, you go ahead and give the second line of drug. Whereas in platinum refractory, you may have to use other things like PARP inhibitors. I won't go into those details. Those things may be required. So these three things are very important. Okay. What is any other, what is bevacizumab?
Sorry to interrupt, only 2 minutes more.
Yeah, we are almost done.
It is a monoclonal antibody targeted against a VEGF, ma'am.
Yeah, whom do
Can
you
be
give?
used both in platinum sensitive or platinum resistant disease, which is found to have a reduced rate of recurrence and progression-free survival rate has been increased with bevacizumab, ma'am.
Okay. So how will you manage this post-op management? How will you follow up these patients? Follow up, suppose you have finished the complete treatment paper, patient has responded. How will you follow up these patients?
For the first 3 months, for the first 2 years, every 3 months, ma'am, we have to follow up them. For the next 3 years,
What do you do during follow-up?
We'll assess the patient clinically first, how she is symptomatically better or not, then CA 125 and CECT if the tumor markers are elevated. Otherwise, we routinely don't do CECT, ma'am.
So clinical examination is very good. Otherwise, we follow up with CA 125 levels, which is what is the role of secondary cytoreduction? When will you do secondary cytoreduction?
Platinum resistant disease or refractory disease to second line chemotherapy agents, then we'll go for secondary cytoreductive surgery, ma'am.
Or a patient who has a single recurrence anywhere, you don't have to give chemotherapy. You can remove the tumor and then follow up and see. That is again secondary cytoreduction. Okay. So I want to just end by saying two things. Of course, in a patient coming with ovarian mass or something, please assess them properly. Ultrasound is a good modality. Yes, when it is menopausal or perimenopausal, we definitely do a CA 125 level because sometimes we have not discussed about low grade and borderline tumors. It could be there. So that is one thing we should do. And whenever there is a suspicion of malignancy, please do not, try to operate them and then send. It's very difficult later on for oncologists to see what exactly has been done. And not only that, by partially treating the patient, the response to chemotherapy later on also will be not very good. So whatever is beyond use, please, you should learn to refer the patients earlier in for patient care. We should not think, okay, we lose the patient if we send off. That should not be the thing. Whatever we do, we should be for patient rather than for us. That's what I would like to tell. Anyway, thanks Sindhuja and Jay Pratibha for presenting. Dr. Senthil wants to say.
Ma'am, I have a doubt, ma'am.
Yeah,
This is my doubt. Ma'am, in advanced ovarian cancer, ma'am, should we say a lymphadenectomy or should we not say, ma'am?
No.
Peritoneal
No.
Are we gaining by doing lymphadenectomy, ma'am?
We should not be doing lymphadenectomy if the nodes are not enlarged.
Okay.
Because remember, its lymphadenectomy also has its own problems by,
side effects.
We are going very close to the vessels. There will be a lot of morbidity, surgical morbidity is there. And there's no point. Anyway, you're going to give chemotherapy for these patients, right? So that whole idea is to remove as much of tumor tissue as possible so that you'll be bulk. That's why we didn't discuss, we have intraperitoneal chemotherapy where you can give in advance. So when most of the tumor tissue is removed, when the small tumor tissue which is left behind, this intraperitoneal chemotherapy will take care. Of course, all these have to be followed by adjuvant chemotherapy or when you're doing interval cytoreduction, you have to follow by the IV chemotherapy which we are giving. But this will help. That's why to avoid too much of morbidity, we will not remove all the nodes, only bulky nodes, which are enlarged nodes which are removed. And remember, all the enlarged nodes may again not necessarily be
positive.
Malignancy. Yeah, yes. It could be metastasis. Of course, in ovarian tumors, it will be more in favor of malignancy, unlike in cervix or endometrial cancer, which may be just this thing. What is it? Reactive and inflammatory nodes.
Okay, ma'am. Thank you, ma'am.
Stage 1, definitely yes. Pelvic and parietic lymphadenectomy should be done. Of course, now again, people are trying to do what is called a sentinel lymph node, mostly again in endometrial and cervical. It has not yet come to ovarian. In ovarian, stage 1 disease, early stage disease, better to do both pelvic and parietic lymphadenectomy.
Okay, ma'am. Thank you, ma'am. Thank you, Sindhuja and Jai Pratibha.
Thank you.
Thank you.
You should learn to talk slowly, child. The second half, you spoke slowly and clearly. The first half, you were very fast.
Yeah, Jai Pratibha has to learn to talk slowly. Yeah.
Thank you. Thank you, Dr. Lata ma'am and Dr. Sendil Kumari ma'am for such a elaborate discussion on this topic, which would have definitely enlightened all the participating postgraduates. Thank you, Dr. Sindhuja and Dr. Jayapratibha. All the best for